You're listening to Admitting Diagnosis, the Journal Watch podcast for January 9th. I'm Joe Elia. We offer news and an interview. This week's interview is with two CDC epidemiologists. It concerns the spread of viral hepatitis in non-hospital health facilities like outpatient clinics and dialysis centers through alarming lapses in infection control procedures. But first, here are the week's top medical headlines. The FDA says it's not necessary to stop taking Vytorin and other lipid-lowering drugs. Elective cesareans before 39 weeks are associated with adverse neonatal outcomes. Parkinson's disease, neurostimulation beats medical therapy, but with risk. And finally, the 2009 pediatric immunization schedules are out. Now some details. The FDA says its review of data from the ENHANCE study convinces it that patients should not stop taking lipid-lowering drugs such as Vytorin, a combination of simvastatin and ezetimibe. ENHANCE found no difference in carotid intima thickness between a group taking simvastatin alone and one taking the combination drug. The combination, however, lowered LDL more than simvastatin alone after 2 years. A study due for completion in 3 years will measure differences in rates of cardiovascular events on the two regimens. Stay tuned. Next, elective cesareans done before the recommended end of the 39th week of gestation are associated with adverse outcomes like breathing difficulties and sepsis. Examining the results in some 13,000 repeat elective cesareans, researchers found that relative to those delivered at the 39-week mark, the chances of a complication were 2.1-fold higher among those delivered at 37 weeks. The rate dropped to 1.5-fold higher in week 38. Nonetheless, the best policy seems to be to set convenience aside and wait for the 39th or 40th weeks. Next, in Parkinson's disease, deep brain neurostimulation with implanted electrodes gave better control of disease symptoms than the best available medical therapy in a 6-month trial. However, the gain was made at the risk of severe side effects. For example, a 10% rate of device-related problems at the 6-month mark. An editorialist in JAMA says that the study convincingly supports findings made by another group 2 years earlier, but says to beware of those side effects. Finally, in this week's news, the pediatric immunization schedule for 2009 has been officially posted. The most important recommendation is that all children from 6 months to 18 years of age receive a flu shot annually. The schedule was published in Pediatrics, and we've got a link to it on our site, which is podcasts.jwatch.org. Our interview was just ahead. We talked with Nicola Thompson and Perz, which might lead to some confusion during the interview since it's being conducted by Joe Elia. But I think you'll sort it out without too much trouble. Here we go. Earlier this week, the Annals of Internal Medicine published a review of non-hospital healthcare-associated transmission of hepatitis B and C over the past decade. The authors, all at the Centers for Disease Control and Prevention, investigated publications detailing the spread of viral hepatitis in surroundings like hemodialysis centers and long-term care facilities. They looked at 33 outbreaks, which caused a total of 448 cases, and they say the cases under review represent the tip of an iceberg. An iceberg, they say, is growing in size. The cause in each outbreak was a lapse of fundamental infection control procedures, some of which were appalling. We've asked the first two authors on the paper, both epidemiologists, Dr. Nicola Thompson and Dr. Joseph Perz, to talk about the implications of their review and how clinicians might help raise awareness of the problem it identifies. Welcome to you both.
Thank you.
Thanks for having us.
Dr. Thompson, can you summarize briefly for us the mode of transmission in some of these cases?
Certainly, and I think as you already mentioned in your introduction, in each of the outbreaks that we identified, there was some kind of fundamental lapse in basic infection control practices, which we refer to as standard precautions. In many of these outbreaks in the outpatient setting, these lapses were directly resulted from the mishandling of injection equipment or injection medications in such a way that allowed blood contamination and then subsequent transmission to other patients. We found similar outbreaks that were attributed to poor infection control practices and injection medications in the hemodialysis setting. In addition, specifically in the long-term care settings, the outbreaks there were predominantly associated with mishandling or reuse of equipment that became contaminated with blood, and that equipment was used for blood glucose monitoring and diabetes control.
And so these are reuses of like finger stick lancets and hypodermic needles, right?
No, and I think it's important that we clear this up. For the long-term care setting, it's not the reuse of the lancet per se, but the finger stick device that holds the lancet.
I see.
And again, in terms of the needle reuse, although that has been identified, what we're seeing more frequently is the reuse of syringes, which allow contamination of multi-dose vials, which are subsequently used on multiple patients.
Dr. Perz, is there a culture of assumption around infection control? That is to say that people think that, well, everyone knows that you shouldn't be reusing these kinds of this kind of equipment, or that you should be taking precautions, especially in the non-hospital setting.
Well, that's an interesting question. I think, on some level, we've assumed that healthcare personnel would understand and maintain basic safe levels of care, and that they would understand, for example, the concept of aseptic technique, that's something that they would have learned pre-service and be able to apply in their day-to-day work. And yet the outbreaks point out that, these aren't just isolated occurrences, but some of the bad practice, if you will, is more widespread than we understood. It's certainly a culture of safety is something that we need to foster to help prevent this kind of transmission. And it is true that in outpatient settings in particular, there's less formal infection control oversight.
Yes.
And so then it really becomes incumbent on healthcare personnel to not only be mindful of their own technique, but to be mindful of the technique of their colleagues and the staff that are responsible to them.
Now, how would a listener, say, accomplish this? Is there, in their approach, say, to an administrator, is there a resource that they could look at before going to an administrator and saying, gee, we had an outbreak of hepatitis or some other disease, and maybe it's time for us to look at our infection control procedures here?
Right, and what I would say to that is that, and it's not just, we've had an outbreak, but we want to prevent outbreaks. And, we're concerned that, some of these conditions that led to outbreaks and large patient notifications and, a lot of negative impact on both the patients and the practices involved, that it's in all of our interests, the patients and the provider's interests, to prevent that from happening. So what can we do to review our practices? Assuming this is, that the audience is, more of the outpatient variety, say.
Yeah.
There are things that we can do, even if we don't have an infection control practitioner on staff like a hospital might, that we could, re-examine as a group our medication handling practices, the way that we prepare injections and handle injectable medications, to reference that against what Nicola, I think, mentioned earlier, which is standard precautions. These were revised in 2007 and are freely available, and we have material on the CDC website that helps direct providers to those materials, and specifically to the injection safety elements that talk about, what are recommended practices and frankly, on the flip side, what's not recommended. One area for review in terms of staff practices would be, some of the real basics, the never stuff, is let's make sure that nobody's reusing syringes or needles from patient to patient. Let's also make sure that we're not reusing single-use medications for multiple patients. And then beyond that, syringe reuse in the context of care for an individual patient can pose risks to subsequent patients if it's done in a way that can lead to contamination of shared medication. So do we have proper precautions in place around any shared injectable medications? Are we using a common source of saline flush for multiple patients? To review those kinds of specifics among staff is something that we are recommending to providers to avoid some of the bad outcomes, both for the patients and for their own practice.
And what I'll do is I will put on our website the URL that I think you refer to in the paper.
Yeah, that's there as well. And we also have a safe injections page that we're building that has some interesting material that listeners might want to look at and you might be interested in.
Okay. I'd like to ask the both of you, with failing education, failing the one's ability to convince an administrator to have such a meeting and to review these procedures, what kinds of sanctions, you mentioned in the paper that the kinds of sanctions that can be brought against a healthcare facility are not uniform across states. And so there are various things that can be done. What sort of sanctions are possible if training doesn't work?
Well, I don't know if it's sanctions per se, so much as just having some form of oversight. From state to state, different types of facilities require different types of licensing and may require periodic inspections, and that's something that needs to be looked at more carefully. Nicola, I think we've found, taking the example from long-term care, this shift of, at least in the outbreak reports, in our outbreak series, we see this notable shift from outbreaks occurring in the skilled nursing facilities to outbreaks occurring in assisted living facilities. Assisted living facilities in many states aren't subject to the same kind of oversight and regulation that skilled nursing facilities are. We can only speculate, but it could be that less oversight is one explanation of the problems that we've witnessed.
And Dr. Thompson, what would you add to that?
Well, I'd just like to continue with, as Joe had mentioned, this very specific issue that we've identified of hepatitis B transmission in long-term care settings. And as you already just heard, we've seen a change in the long-term care venues that these outbreaks are occurring from nursing home and assisted living to assisted living facilities. And these facilities vary vastly in their size and the number of patients that they have and who they're taking care of. But, one of these areas that seems to have been overlooked is blood glucose monitoring, and I think there's an underappreciation and a misperception that something that is considered as simple as routine blood glucose monitoring that is performed multiple times daily on some of the residents of these facilities can actually be involved in transmission of blood from patient to patient if the recommended practices aren't followed. And so it's important for people who are working in these facilities, whether they be administrators or nurses or technicians, and those agencies that are responsible for regulating and overseeing and licensing these facilities, also take note to the specific recommendations for providing safe blood glucose monitoring in long-term care facilities.
The number of patients, the populations of these facilities are growing, aren't they?
That's correct. There's going to be significant increases in the number of people who are residents of these facilities, and they will continue to grow. And an additional concern of ours is that as the population of people that we have here in the U.S. with chronic bloodborne pathogens, which includes hepatitis B, but also hepatitis C and HIV, continue to age, the prevalence of persons with these infections in these settings will also increase. And so if these practices continue unchecked, it would not be unreasonable to think that this type of transmission will continue and increase.
You mentioned in the paper that about half the reports of these kinds of outbreaks don't detail the cause of the spread.
I'll leave actually more of this for Nicola, but physicians can really help address the problem by reporting any suspected healthcare-associated transmission of hepatitis B or hepatitis C to health departments. In order to deal with this problem, we have to do a better job of recognizing it.
Just to continue on from Joe, in that we are aware that the current surveillance system that we have for viral hepatitis is inadequate to help us detect these types of outbreaks, and we list a number of reasons in the paper as to why that is. And one of them is that we know that many people who become infected with hepatitis B and C will be asymptomatic, and their infections may go undetected for a long time. The other issue is that many of the reports of cases of acute hepatitis B and C that are identified and diagnosed that come to the health department come in without an adequate risk factor profile completed, so it's difficult to determine where someone acquired their infection. But as Joe was just mentioning, that physicians have an important role to play in this when they have patients who are newly diagnosed with hepatitis B and C, and there is an absence of the traditional risk factors for these infections. Then they should be concerned and wonder where these infections came from.
Okay.
I was going to say that a number of the outbreaks, in fact, were detected not by our traditional, public health surveillance, but more so the informal network that relies on alert clinicians. So a number of the outbreaks were picked up because an alert clinician noticed that there were, 2, sometimes more cases, that had a common healthcare exposure, and then brought that to the attention of public health authorities, and then that presents finally, an intervention opportunity to take the pump off the handle, if you will.
Yeah.
With the outbreaks that we describe, actually, we have a pretty firm sense of what the mode of transmission was for all of them, frankly. But the background cases, the sporadic cases, there's more of an unknown there. This is an area that, is really a great concern to CDC and to us as epidemiologists working in healthcare. And so, one of my sort of parting messages would be, a reminder to clinicians to reestablish, infection control and injection safety and other basic patient safety measures as part of their facility or their practices priorities, and really make it a part of ongoing quality improvement.
Well, good. I want to thank you both for participating in this today.
It's our pleasure. Thank you for having us.
Finally, 2 things. First, I put links to the latest top stories of the year from Journal Watch on the website, podcasts.jwatch.org. And second, we reported in Physicians First Watch last week that several drug companies have agreed to stop handing out product-emblazoned pens, coffee mugs, and the like. I'm not without guilt in this matter, even though I'm not a physician. I've got to admit that I've been carrying around a little Intron pen that I found on a plane at least 15 years ago. I even got a refill for it, and it still works just fine. But maybe I should send it back. Well, have a great week of healing. And if you want to comment or complain, call 617-440-4374. If you'd like the links for any of the stories or access to any of our interviews, go to podcasts.jwatch.org. Our executive producer is Adoriano, and I'm Joe Elia, in charge of all the non-executive stuff. We'll see you next week, and thanks for listening to Admitting Diagnosis.